like everyone's a little bit afraid of TMJ and uncovering its mysteries. So we're going to do a little bit of some TMJ diving here today. You guys are going to get to know how it works, some of the common things that we manage with TMJ, and how we go about it. And so just to review basic ground rules, I love questions, but if you're going to ask questions, I need your video to be on. All right. So no questions from the black ether. Cool. Let's do it. So we see this over and over again, right? Now this time it's not labeled. So we're going to go through it. We're going to identify the parts of the tooth. On the left side here first, the first two are really, really easy. So I'm just going to click through those two because those two don't really count so much. We have the crown and we have the root of the tooth. I'll give you the first one. It's a freebie. And then I'm going to start calling on names, folks. Sorry. So the outer layer of the tooth is the enamel, protective coating, right? What is the next layer, Alex? Alex, what's the next?
Oh, sorry. Is that the dentin?
Perfect. All right, and Sarah, what do we have next?
The cementum, I think.
All right, so this right here, what are we?
Pulp.
The pulp, exactly. All right, Michaela, next in line here, what is this pointing to?
The gingiva.
The gingiva, perfect. All right, let's see, Sophia, the next structure here that's being identified is?
The cementum.
Perfect. All right, so it's like the continuation of the enamel. It's the protective coating for the roots. All right. This one gets a little bit squirrely because it's kind of pointing to the things that we find inside the nerve chamber, or inside the pulp chamber, which are, let's see, Aline, are you with us? You may be frozen there. All right, Header, what do we have here? What are the structures inside the pulp?
I believe those are the vessels, blood vessels.
Okay, and
I see the nerve too, perhaps.
Perfect. Yep, nerve and blood vessels. So this is pointing to the blood vessels. Down here it points to the nerve, but exactly. The pulp is composed of interweaving blood vessels and nerves. And then the next one here. So this is the shock absorber for the tooth, right? Emmanuel, what are we looking at?
The periodontal ligament.
Perfect. Yep, it's a periodontal ligament. Exactly. And Daniela, towards the tip of the root, that main branch branches off into what we call the what?
Ligaments canal.
They're canals, but they are lateral canals. All right, so it's like branches, like branches off a tree, right? And there are thousands of these little branches that happen from that main central canal. Cool, great job, guys. Okay.
You're making me want some.
So let's talk a little bit about some of the recent research that's being conducted on the correlation between dental problems and COVID manifestations. One very interesting thing that we're seeing, and there was just a paper released on it, is that people that have had or that have gum disease develop much more severe manifestations of COVID. They are 4.5 times more likely to be placed on a ventilator and 9 times more likely to die. That's huge, right? And we believe the reason is because COVID really kills from like a massive inflammatory response. And gum disease is an inflammatory condition, right? So anywhere where we have excess inflammation, it's just almost like adding fuel to the fire, right? Like you're pouring gasoline on COVID. So really, really interesting. Needless to say, a lot of research being done, a lot of information is coming out. We really don't know the full extent of the relationship between the two, but we're learning more and more every day. Now, I can tell you guys from being in practice that, you know, we don't really see the people that are placed in ventilators and that pass from COVID, right? Like, we're doing clinical dentistry. And what we're seeing happening in the mouth is also really interesting, and we're like totally perplexed by. Three big areas. We've seen ulcerations and something called COVID tongue, which is like these white patches on people's tongues. And all these ulcerations, people have no past history of this. There's nothing we can point at to be like, all right, that's the cause for the ulcers. And it's just happening. And these folks are COVID positive. And sometimes we're actually diagnosing people with COVID from the oral manifestation. So this right here clinically looks like a herpes outbreak. All right, this is exactly what a herpes outbreak looks like in the mouth. This person doesn't have herpes. Never had herpes before. So this was a COVID manifestation. And it resolves, it goes away, never comes back, right? But it can be painful, it can burn. Like, they can have like burning tongue syndrome. They can have areas of soft tissue pain that don't really have any sort of like like pathology that we can point at. Really interesting, really weird. Another thing that we've seen is much faster like bone breakdown from infections and things like that. What used to be kind of a slow process of abscesses forming, and we'd see these dark areas on X-ray, now goes 0 to 60 really, really fast. This is a patient of mine, and this is a 2D X-ray, but we took a CT scan on her, and we were able to see the bone in 3D, and this infection just ate right through her jawbone, like through and through, made a big hole in her upper jaw. And I had never seen anything like this before. I've been in practice for almost 10 years, been in dentistry for 4 more additional years. Never have I seen this fast of an issue with people's bone breakdown. The other thing is a higher susceptibility to opportunistic infections. So we see a lot of thrush, a lot of Candida, right? So this is a fungal infection. You can wipe this off with a piece of gauze, and the tissue underneath is like this raw, bleedy mucosa tissue. And it'll happen in the vestibule, right, where the lips and the ridge meet. It'll happen on the tongue, the floor of the mouth, like the back of the throat. So a lot more fungal infections we're seeing too in folks that have been COVID positive. This may also have something to do with mask mouth, right? With just like the general environment inside the mouth changing from wearing masks all the time. Again, a lot of research being done. We don't have concrete answers yet. Now, another huge area of dental impact from COVID and COVID fallout is on the TMJ. All right. TMJ means temporomandibular joint. It is the interface between the temporal bone of the skull and the mandible, or the lower jaw. This is a fascinating joint, guys. Super complex ecosystem. I'm going to take a little bit of a zoom inward here. So here we have the skull. Here we have the mandible. A couple of things come together. So the jaw joint is like, if you were to cup your hand and put a fist there, it sort of sits like that. And then you have like this, like an ice cube, right? A slippery ice cube for the two things to sort of glide on each other, right? That slippery layer is called the disc. It helps lubricate and facilitate that motion of the joint. So we have the fossa, which is like the cupped hand. We have the condyle, which is the part of the jaw that engages that. And then you have that squishy layer, which is the disc buffering all of that. That squishy layer is held in place by like bungee cords that are ligaments. And everything is obviously controlled by muscles, right? So it controls everything in the body. So this muscle down here is one of the primary movers and closers of the jaw, called the masseter, right on the side of your jaw here. And the other big one is the temporalis on the side of your head, right? It's a large fan-shaped muscle. And we have pterygoids, which are smaller muscles that contribute to the whole thing. But these three things, the fossa, the glenoid fossa, the condyle, and the disc, we need to know like that tooth anatomy chart, like the back of our hand. So now, when that joint opens, it doesn't just rotate in that fossa. It rotates and then it slides down the eminence. It's called the articular eminence. So here we have the fossa, and as the jaw opens, it first rotates in that fossa and then like ice skates on the disc all the way down, and then ice skates up and rotates back in place. That's a really, really complex, like orchestrated motion that happens here. And it's all contingent on this disc being and staying in the right place. And it's held in place by those bungee cords, by those ligaments and muscles, right? So all of this to say that this super complex motion sometimes goes haywire. And we call that haywiredness TMJD, or temporomandibular joint dysfunction. Now, people will often say when they have jaw pain, it's like, oh, I have TMJ. Yeah, everyone has TMJ. That's the joint, right? But now we know that the symptoms is a dysfunction of that joint, okay? And that dysfunction can happen from multiple different things. Sometimes the disc is unhealthy, right? And it's inflamed and you have a discitis. Really rare. It happens, but it's rare. Sometimes it's bony, right? And if you start developing arthritis in this joint, and now this condyle, instead of being smooth, is all rough, and it's like creaky when it like glides in the fossa, that's not going to be good either, right? But that too is relatively rare compared to the number one thing that we'll see in just a second. So the range of symptoms can be worn or broken teeth, jaw pain, headaches, including chronic migraines can be stemming from a TMJ dysfunction. And frequently, we'll get people that have tried all sorts of different approaches to manage migraines, and they finally just come to the dentist because someone told them, hey, it could be that, and we'll treat them for TMJ and they get better. Like they can get off medications, and it's really, really powerful. And trismus, or lockjaw, right? Trismus is the technical term for lack of range of motion. Now, the number one risk factor for all of those things and TMJ dysfunction is stress. There is a huge correlation between stress and TMJ symptoms, TMJ dysfunction. And who hasn't been extra stressed during COVID times? You guys, it's been tough, like having to transition to the online approach. Everything's been turned on its head, right? It's the bus driver that now has to cover an extra shift because their coworker woke up with a cold, right? And wouldn't dream of coming into work. And just the new reality has us all a little bit more stressed out. And thankfully, we're all learning how to cope with it and deal with it and get by. But the baseline of stress is undoubtedly increased. So we've seen clinically a big fallout orally from the stress-induced TMJ issues. So we'll get into this a little bit here. One of the things that we see with TMJ issues isn't just the pain and the broken teeth and stuff like that, but as we grind our teeth down because we're more stressed, it actually induces premature aging. Take a look at this diagram here. The noses are parallel, right? All that changes is the support on the lower third of the face. As you grind your teeth down, or we break teeth, right? Which is one of the main things that we do when we're stressed out, for people that carry stress in their jaw, which is a big percentage of the population, is you start losing support for the chin. So the chin starts getting closer to the nose and it prematurely ages the lower third of our face. Some folks don't even care about being in pain, but when they know they're going to get older sooner than they should, they start listening. So we all know, right? Like if we're chewing on stuff, like we're clearly going to grind our teeth down a little bit, but how much is too much, right? Like what is the normal rate of wear of our teeth from like normal chewing and talking and doing all that stuff? Who wants to venture a guess? Anyone? How long do you think normally it would take to wear down, let's say 1 millimeter of tooth structure? Not a whole lot.
Maybe like 10 years?
Yeah, 10 years I was going to say.
10 years. Okay. 100 years. So 1 millimeter, in dentistry it's a lot, but really it's like not all that much. Like it's really, really little. For 100 years. That means that the normal amount of wear for teeth is basically imperceptible, right? Because we get our adult teeth, like let's say our molars and our premolars at like 6 to 12. So we'd have to reach like 106 to 112 and worn off 1 millimeter to be in the normal range, right? Like that's almost nothing. So if you can see wear on someone's teeth, if you can see wear on your teeth, it's pathologic wear. It is excess wear and tear. And someone's going to charge you extra when you return it for the excess wear and tear. So this is a patient of mine. A whole lot more than 1 millimeter of wear. If the average lateral incisor is 10-ish millimeters tall, 10.5-ish millimeters tall, we had about 4 here. So if he were celebrating his 600th birthday, he'd be right on track. He wasn't. So this is a really severe example of pathologic wear. This is him after his reconstruction. He was super happy with it. We got a great result. You can see he still has a lot of wear on those lower teeth, right? But these are still at least functional. All right, he can smile now. Really, really powerful stuff. Really powerful stuff. He was super happy with the result, but you know, had we caught this earlier, it wouldn't have cost him many, many hours of dental treatment and a whole lot of money, right? So all of these things, like with everything else that we've talked about, catching it early, intervening early when it's minimally invasive is the way to go. It's our responsibility. Now, another big thing that we've seen a lot isn't just worn down teeth or jaw pain, but it's cracked teeth, broken teeth, like literally split down the middle. Patient of ours came in, this is tooth number 12. So this is the upper left first premolar. And the picture, it looks like it's the upper right, but that's because we took it off of a mirror and it wasn't flipped. In any case, look at that. Look at that crack right down the middle. He literally just like split the tooth apart. And he was eating, you know, every patient that comes in with something like this, like, I don't know, doc, I was eating like chicken salad. It was something soft, right? Like we don't do the damage. We don't create the break while eating, right? We're stressed out and we're sitting in traffic and we're clenching our jaws and we're like, man, this guy just cut me off and I'm going to grind my teeth to bits, and I'm sleeping and I'm like just venting all the stress of the day and just grinding on things. And those fractures just start like getting deeper and deeper and deeper till the tooth just gives way. All right. So what do we do at this point? Nothing. There's nothing to do at this point. We got to take it out. All right. Look at how deep that crack went. Like you can follow it down. So this here is the enamel of the tooth. This darker yellow thing, yellower part here is the cementum. So here we have the CEJ, right, cemento-enamel junction. This just crossed right through the CEJ and split the two roots apart. So we took the tooth out. Here's the socket. Nice atraumatic extraction, was able to preserve the bone in between. So this upper premolars usually have two separate roots. Okay, we have a buccal root and a palatal root. And whenever we want to take a tooth out and replace that tooth with an implant, we want to protect as much of the bone as possible around that area, including the bone that would be like right in between the two roots, right? We call that the interseptal bone. So that's what we did here. We removed the two roots, we placed an implant, we packed a little bit of bone around the implant and gave him a temporary tooth to wear until we're able to restore the implant. So when we are dealing with, you know, folks that have TMJ symptoms that we suspect are overstressing the system and putting a lot of wear and tear on things, we got to come up with a plan, right? And it's usually a two-prong approach. One, we protect the teeth themselves from damage. And two, we want to modify the muscle behavior leading to the excess wear and tear, right? Because the joint is all really complex, but it's all controlled by muscle, all right? And the two major muscles responsible for that are masseter, like we talked about, and temporalis, okay? So let's see what we do for these two areas. Number one, we always recommend at-home care, right? Because we're limited in how much treatment and how much we can help people. They're always with themselves and they can help themselves a lot at home. And it's usually fairly simple things. And it's just tips and tricks, right? And you guys should be aware of this so you can share them too. Number one, massage. Literally just massaging these muscles and helping those muscles relax, right? These muscles sometimes work so much, like they start spasming, they get overstimulated and they're tight, right? And just helping them relax helps unburden the system. Stretching, simple range of motion exercises, opening as far as they can without pain, sticking their jaw out against resistance, opening against resistance, going side to side, right? And just sort of like stretching those muscles and ligaments, all those bungee cords, helping them relax a little bit. We advise diet modification. So don't go eating bagels, right? Like super chewy, hard foods. Like stick to a softer diet for a few days. And believe it or not, posture, right? Like we get like tight and like crimped and we're all sitting in front of like laptops all day. And like everything just starts getting uncomfortable, right? Like practicing good posture. And I'm glad I'm talking about it because I'm catching myself in my hunched over bad posture, right? But like sit up straight, shoulders down, nice and relaxed, right? Everyone is like minding their posture. That's great, right? Everyone feels more relaxed now. Awesome. Tongue clicks. So helps people. It just helps certain muscles relax inside the mouth that may be a little tight and are otherwise hard to get to and stretch and relax. And heat and cold, right? Just applying heat and cold. And one can be better than the other, and everyone's different. Like some people respond better to cold, some people respond better to heat. It really is whatever works for you, right? And these are just things that folks that have those symptoms can do routinely to lessen the blow, so to speak. But how can we help, right? And when we talk about protecting the teeth, number one on the list is night guards, right? Everyone's heard of a night guard. Many of you may have had one recommended or made. And really night guards, as far as the basic flat, plain occlusal guard, it is putting a layer of plastic between your teeth, all right? So that you gnaw away on plastic and not your teeth. This does hardly nothing for the root cause or the behavior leading to the symptoms, right? But it is very effective at protecting teeth. Like if you wear a night guard, if you're a grinder or a bruxer and you wear a night guard, you're not gonna wear your teeth out anymore. You're not gonna crack teeth unless you crack it when you're sitting in traffic, you're fit of road rage, right? Which happens too. And sometimes I recommend to people like, dude, like carry your night guard with you. Like take it in the car. If you start feeling yourself getting amped up, pop it in, gnaw on that for a little bit, right? It's almost like a chew toy to de-stress. So they're great, but they rely on patient compliance, right? Just like everything else. Brushing and flossing and water picking works great to prevent periodontal disease, but that too relies on patient compliance, right? So we recommend a lot of things that requires the heavy lifting at home because that's how we can prevent things from getting worse. Another really interesting type of night guard, all right? It's called an anterior deprogrammer. Now, I want all of you guys, as many of you guys as you can, like turn your video on because this is going to be a fun little exercise that we're going to do together. Cool, folks coming online, dig it. All right, fair enough. So I want everyone to get a pen. Does everyone have a pen available? Cool. I want you guys to first evaluate and feel your masseters and your temporalis when they engage. So right around here, you're going to clench and release, and you'll feel it pushing your fingers out, right? Clench and release, clench and release. You're going to feel that big muscle there doing its thing. Now we're going to go right above the temple, and we're going to do the same thing. So right around this area here. All right, everyone feel that? Cool. Now, take your pencil. I don't have a pencil, I have a highlighter, so it's going to be a little weird. And we're going to put it right between our front teeth. And we're going to evaluate again. You can barely feel it, right? So what happens is these muscles know that they can clench when our back teeth are touching, because those are the teeth designed to grind and crush food and really put a lot of force on things. Our brains know that when only our front teeth are touching, if these guys engage, we're going to break those teeth. These teeth aren't designed to take all of the pressure that these muscles can exert. So an anterior deprogrammer displaces all of the occlusion, or how the teeth come together, to a single point in the front, thereby disengaging these muscles. Pretty cool, huh? So this thing has different names. It goes by NTI, Lucia Jig, all sorts of different terms and slightly different designs, but it all basically does the same thing. It keeps a posterior, right, meaning towards the back, open bite.
Dr. Alex, would that cause you to sleep with your mouth open?
Yeah, it's not the most comfortable thing or attractive. Like if you're going to bed with your spouse and pop that in, hi honey, it's whatever.
Yeah,
It does its thing though.
Does it, so let's say you had like orthodontic treatment done in the past. Like I used to sleep with my mouth open. So my dentist said that my teeth would, from breathing in and out, I would have like an overbite for sleeping with my mouth open. So
Okay.
sleeping with that in, would it cause it to like shift in any way or?
Yep. So it can lead to occlusal changes, right? If we wear this thing chronically, it's going to lead to things moving around. So it's not something that we want to recommend for like indefinite use, right? This is almost like having a back brace. This is how I compare it to patients. So you have a back brace because you have some back issues. Like you don't wear the back brace all the time because it's just going to end up weakening the muscles around it and making the back issue worse. Mm-hmm. Right? But when you have periods where you feel like, oh, things really aren't so good, you can put it on. It'll give you a little bit of help.
Yeah. Or if you're really stressed.
Yeah. And people know, I mean, people that carry stress in their jaw, which is a really large percentage of us, like up to 70% studies show that will sort of like, it's an escape valve. The clenching and the grinding is an escape valve for our stress at night. And we know, like we wake up in the morning and you feel like you've been chewing gum all night, right? Like things just feel stressed. Your teeth may be a little bit sore. So you pop this thing in and it helps you relax for a few nights, right? And sort of break that cycle of constant stress on the whole system. That make sense?
Yeah. I don't have another question, but I wanted to let you know. So I was shadowing a dentist like 5 months ago, and she just hired me like 2 weeks ago as like her dental assistant. But mind you, like I've never done like any classes or anything. So I always hear her saying, oh, you have bone loss. Well, not to me, like to her patients, she'll be like, oh, you have bone loss, like because of infection, this and that. So then one time I was home and my mom was like, oh, let me be your first patient. So then I was like playing around with her mouth, and then I noticed that she had bone loss, but I'm like, that's so weird because she brushes her teeth like really, really well. Like there's no way she has infection. So we went to the dentist and he said that because she was so stressed, that she was grinding her teeth so much that she was wearing down her bone. So they sent her a night guard. But the thing is, she's really, really claustrophobic. So she doesn't like sleeping with that thing in her mouth because she just like gets like super anxious. So I'm going to show her this, and I don't know, maybe she'll do it. I'll let you know. But yeah, that sounds cool.
Yeah, you're right. And it's a good point. So one of the things that can happen when we overstress the system is that we see some breakdown of the bone around our teeth. It's kind of a debated topic in dentistry, if it can happen as a standalone thing, or if we have to have had some gum disease at some point that started the bone loss process, and then the clenching and grinding sort of took over and sped it up. So yeah, it's a good point. We do recommend, just like your mom's dentist did, I think it's a good suggestion. And recommendation for mom is wear the guard during the day as much as you can, because that desensitizes you to it and makes sleeping with it a lot easier.
Uh-huh. Thank you.
Cool. Yeah. So the other thing that we do, so the anterior deprogrammer is great, right? We don't want to wear this indefinitely because it can change the position of our teeth, but it works, helps muscles relax. The other thing that helps muscles relax is Botox. We talked a little bit about Botox 2 weeks ago with the Pink Aesthetics part of the lecture, right? Gummy smile, managing the gummy smile. So we know that what Botox does is it's just targeted muscle relaxation, right? We force a muscle to relax, and we force the muscle that we want to relax for 4 to 6 months. So Here we have a diagram. This is the temporalis. This is the masseter, right? So what we do is we use the medicine directly into these muscles and force them to chill. We don't paralyze the muscle completely, right? Never want to do that. People still have to chew. But we're just taking it from like max contraction of like 12 out of 10 to max contraction of 4 out of 10, right? So a little tidbit of information, a little nugget. The absolute hardest things that we eat, nuts, right? Pistachios, almonds, things like that, take about 100, up to like 150 PSI to break down, right? Pounds per square inch in our molars. So the hardest thing, so functionally, we just need to exert about 150 PSI with our jaws to eat and talk and normally. When we clench and grind at night, that PSI shoots up to around 1,000. 1,000. That's a huge difference, right? What is that? Like 7 times as much as we need to chew the hardest thing. So it's damaging and we can do something about it. I put this slide in here because many of you guys may not know how Botox works. Like everyone's heard of Botox, but no one really knows a whole lot about it. Everyone knows it's it either, you know, like helps you with your wrinkles or it's a poison. It's both. Everything's a poison if you use too much of it, right? But in any case, I wanted to show you guys a vial of Botox and what it looks like and what we have to do to use that medicine. So when we buy Botox, when we get the vial from the manufacturer, all of the medicine is this little white halo at the bottom of the bottle. You guys see that little white ring of dust at the bottom there? So what we have to do is we have to do something called reconstituting. And that means we're gonna put it in solution. We're gonna put bacteriostatic solution, right, sodium chloride, and we're gonna dilute it. So we take up a measured amount, 2.5 mLs, pour it into the vial and spin the little tube and mix in all of the medicine in the solution. Now, we always use a set amount of liquid in the vial because this is 100 units of Botox total. And we want to know exactly how much liquid we need to administer the right amount of Botox. Right, we administer the medicine in what are called units, okay? And the average TMJ treatment is around 40 to 50 units of Botox. A needle comparison. So this is an IV needle, this is an IM needle, and this is a Botox needle. So it is literally insulin needles is what we're using. Like they're super short, super thin. When patients get sketched out about the injection part, because people don't like to be injected. Like I've taken these and just like put it in my arm in front like an acupuncture needle, and people are like, "Oh my God, you don't even feel it, right? It's just like a nothing." So it's a teeny tiny little needle, and what we do is we distribute the medicine around those two muscles, right? Primarily the temporalis and the masseter. And we have certain reference landmarks so that we stay in safe zones of the muscle, because there's a whole lot of muscles happening here in the face, right? Like we don't want to miss and relax the wrong thing, right? Because that's when folks start getting a lopsided smile or droopy eyelids, and then they're relaxed, but well, they're pissed. They just can't express it to you. So not a good place to be. So we have safe zones, right? What we'll do is we'll draw an imaginary line from the corner of the mouth to the tragus of the ear, which is the little nubbin in the earlobe, right? So right there, we stay south of that line. We'll stay above the border of the mandible, right? And then we'll feel All right, we'll have the patient clench and release, and identify where the anterior border of the masseter is. And that's our safe zone there. So we'll distribute the medicine. 5 is usually a lot. So it'll be 2 to 3 shots. And we'll do that depending on the patient, how many like hyperactive areas they have, right? Like you'll feel different bulging areas of the muscle. And we'll do the same thing with the temporalis. And this is actually, we're doing it in-house. This is one of your former classmates helping me out here. This is Connie, my lead assistant, and she gets Botox treatments fairly regularly, as does my office manager and half of my team. Maybe that says something about me. I don't know. It's a moment of introspection. My wife too. So connecting the dots here is, In any case, it's really, really effective. Once people get it done, like big things that they report is no more tension here, right? Resolution of headaches is a very common thing, and improved sleep quality, right? Like you can just imagine if this is going haywire and you're gnashing and clenching and doing this and that, like it's not contributory to a nice, relaxing night of sleep, right? So people wake up more refreshed. They literally sleep better when we help them with that clenching and grinding. So next week, we're going to be talking about undoing the damage. Very excited for next week. So we're going to be talking about partials, which aren't sexy, but they're super effective. Right? So we'll touch on those. We're going to talk about bridges, crown and bridge work, and implants, which are very near and dear to our collective hearts. And quick announcement, registration for our program is open. We have not been having any classes for the last year because of COVID and social distancing. But now as everyone's getting on board with their vaccination and social distancing and PPE protocols are a lot stronger, we're going to be kicking off our next session late March. So registration is open now. Any questions about TMJ, COVID, or night guards, or Botox, or implant?
I wanted to ask if there were any side effects to Botox treatment for TMJD.
Yes. So potential side effects, sure. Number one on that list is user error. So like relaxing the wrong area, especially when we're doing a lot of units in the masseter. Sometimes we can hit some of the risorius muscles, like some of the ones that like pull our lips back to smile, and it'll give patients like, a lopsided smile. Allergic reactions are extremely rare. They can happen, but I've never had one personally, thank God, nor have I had any of my colleagues ever have any direct encounters with an allergic reaction, but it could happen.
Okay, thank you.
Yeah. Thanks for the question.
I have a question about night guards. I had to get one after the pandemic started because, as you mentioned, COVID stress. So I started having TMJ issues, and I basically use it like a chew toy. But then I wake up with changes in my bite. So do night guards also have occlusal changes as an effect?
They can, and it's usually transient. So you probably noticed that you first feel that when you first wake up in the morning, and then a few minutes later, things settle back down. Mm-hmm. So night guards are generally designed to be like very flat, so that when you bite down, everything is sort of hitting very evenly. And what we try and do when we adjust the night guard is maintain that evenness throughout all the movements of the jaw, right? Because your jaw isn't just clenching down, it's sliding around and pressing down and doing all those different things. Sometimes we end up having a preferential way to gnash on it. And instead of just being evenly distributing it all, you'll bite down more on one side throughout the night. And then when you take it out, you've changed your bite a little bit.
Right.
Now the PDL compensates for that and resettles it back down generally quickly, but sometimes it can be like it sort of builds on itself, right? So how are you doing with it?
Pretty good. I just feel like I keep chewing on it too much. It makes you want to chew on it because of the plastic, but yeah.
So is it a soft or hard?
I think, I mean, the edges are hard, but where I bite on it, it's soft. So it makes me want to bite on it more.
Okay. So yeah, so night guards should never feel like an athletic mouth guard, right? So mouth guards for sports are like a rubber, almost chew toy consistency device. Night guards should be a very hard plastic, because what we know is that when it's a little bit rubbery, it's almost like you're putting chewing gum between your teeth. So it stimulates that drive to even clench more on it. Whereas when it's a hard piece of plastic, you don't have that drive to just keep gnawing on it. So yeah, I don't know. Maybe we can try with a different kind of night guard for you, and maybe it cuts down on that.
Okay, thank you.
Yeah. Any other questions, guys?
I have one question actually.
Shoot.
How common are cracked teeth in like young individuals? Because typically I picture it as something for like older people who maybe are going through like midlife crisis, etc. But in young students or something, like, is it that common at all?
Yeah. Yeah, it happens. Happens quite a bit. And I've had, identical to the case that I showed you guys of the split tooth, in the last 6 months, I've had 4 or 5. One of those was someone under the age of 25. So is it more common in people that have had more cycles of clenching and grinding in their teeth? Yeah, for sure. But it happens for young folks too. Now, for younger people, we'll see a lot more of like cracked cusps and broken fillings and things like that. So things that we can fix with crowns, not necessarily having to remove the tooth and replacing it.
Awesome. Thank you.
Can that happen with like you said, if somebody cracks their tooth in half, does that only happen if they have a filling? Like, let's say the tooth is intact, can you still break through it?
Yeah.
But isn't
100%.
an animal supposed to be like super, super strong?
Yeah. Yeah, it is super, super strong.
But you can still crack through it? I had a dream the other day that I don't know why, like, this is so weird. I was biting so hard that I cracked through all my teeth, but that was my dream.
Ah, you're having the dental dreams.
Oh
tooth
no,
dreams.
I woke up
Yeah.
and I was in so much pain.
Yeah, and as you guys progress through your career, you're gonna have the cracked tooth dream. You're gonna have the teeth falling out dream. That's a super common one, where you wake up and all your teeth fall out of your head. Or like snaggletooth dreams, where they start shifting around. Oh yeah, it's coming, folks.
But at least you know it's meant to be. If you have those dreams, like, at least you know we're on the right track.
Sure, that's looking on the positive side. I like it.
Okay,
Never mind.
that. But yeah, my teeth are fine. Don't worry.
Good.
Thanks.
Good to hear. They look great from here.
Oh, thank you.
All right. Any other questions, guys? Cool. So in that case, next week, we'll talk about how we undo damage, right? How we replace teeth. It'll be an exciting one. Come with some questions. All right. I will see you guys then.